Welcome to your comprehensive audio guide on lower limb anatomy, titled The Blueprint of Movement. In this opening slide, we establish a foundational overview of the four primary muscular compartments governing lower limb motility. These divisions are strategically categorized by function, neurological innervation, and clinical relevance. We observe the anterior compartment highlighted in structural blue, driving knee extension and hip flexion via the femoral nerve. Adjacent is the medial compartment in surgical green, dedicated to thigh adduction through the obturator nerve. Posteriorly, the posterior compartment is designated in arterial red, facilitating knee flexion and hip extension via the sciatic nerve. Finally, the lateral compartment in yellow manages eversion. Understanding this fascial architecture is paramount for evaluating biomechanics and clinical syndromes like compartment entrapment. We begin our detailed regional analysis in the gluteal area, focusing first on the superficial gluteal musculature. This group serves as the primary engine for bipedal extension and pelvic stability during locomotion. It comprises four principal muscles. First, the gluteus maximus, which originates broad from the ilium, sacrum, and coccyx, inserting into the iliotibial tract and gluteal tuberosity. Innervated by the inferior gluteal nerve, it executes powerful hip extension. Second and third, the gluteus medius and minimus arise from the outer iliac, wing and insert, onto the greater trochanter, under the control of the superior gluteal nerve. They act as critical hip abductors and pelvic stabilizers, keeping the pelvis level during single leg stance phases. Lastly, the tensor fasciae lati assists in stabilizing an extended knee and bracing the lateral thigh. Transitioning deeper into the region, we encounter the deep gluteal rotators, which function essentially as the steering mechanism of the hip joint. While small in volume compared to the superficial layer, these muscles are vital for joint alignment and dynamic control. Their collective primary biomechanical role is the lateral rotation of the extended thigh. Foremost among these is the piriformis, originating from the anterior sacrum and inserting into the superior border of the greater trochanter, innervated by direct sacral plexus branches. Below it lie the triceps cocci group, consisting of the superior and inferior gemelli along, with the obturator internus, followed by the quadratus femoris, and the deeply seated obturator externus. Together, they form a dynamic stability cuff protecting the hip joint. This slide transitions theoretical anatomy into critical bedside application. First, we review the safe zone for intramuscular injections to avoid catastrophic damage to the massive sciatic nerve and associated neurovascular bundles located medially and inferiorly. Injections must strictly occupy the upper outer quadrant. Second, the slide illustrates the Trendelenburg sign. An injury to the superior gluteal nerve paralyzes the gluteus medius and minimus. Consequently, when the patient stands on the affected leg, the contralateral hip drops pathologically due to abduction failure. Finally, we address piriformis syndrome. Spasm or hypertrophy of the piriformis muscle compresses the closely underlying sciatic nerve, causing sharp, radiating pain that perfectly mimics discogenic sciatica despite a completely normal lumbar spine. Before us is the master summary matrix for the gluteal and deep rotator compartments, condensing our anatomical journey into an organized, high-yield table. This matrix cross-references the muscles into three precise functional groups. The superficial extensors feature the gluteus maximus, driven by the inferior gluteal nerve for powerful backward drive. The superficial abductors bundle the medius, minimus, and tensor fasciae lati under the superior gluteal nerve for stability and abduction. The deep rotators group compiles the piriformis and its distal companions, receiving direct sacral branches and the obturator nerve to turn the femur externally. Note the vascular footnote. The superficial layers are heavily supplied by the superior and inferior gluteal arteries, providing a robust collateral network. Moving distally down the limb, we explore the anterior thigh compartment, characterized by its dominant functions, knee extension and hip flexion. This entire operational unit is under the neurological governance of the femoral nerve. Key components include the sartorius, the longest muscle in the body, which uniquely crosses two joints to flex, abduct, and laterally rotate the hip while flexing the knee. Next is the iliopsoas, emerging as the chief and most powerful flexor of the hip joint. It is flanked by the massive quadriceps femoris, composed of 4 distinct heads that converge into a shared tendon inserting via the patella to the tibial tuberosity, serving as our primary knee extensor. The pectineus and articularis genu round out the compartment, protecting the joint capsule during extension. We now focus on the medial thigh compartment, the primary adductor powerhouse, drawing the lower limb back toward the body's midline axis. The distinguishing structural signature here is that this entire compartment is under the explicit domain of the obturator nerve. The muscular lineup features the slender gracilis, which adducts the hip and assists in knee flexion. It is supported by the classic adductor trio, the adductor longus, adductor brevis, and the massive adductor magnus. Note this crucial clinical variation. The adductor magnus is a hybrid composite muscle. Its adductor portion is supplied by the obturator nerve, whereas its hamstring portion is supplied by the tibial division of the sciatic nerve. The obturator externus completes this functional medial wall. Positioned directly opposite, we find the posterior thigh compartment, clinically and colloquially known as the hamstrings. The shared biomechanical mission of this muscle group is knee flexion and hip extension, essential for normal gait propagation. The primary neural highway driving these movements is the sciatic nerve, specifically its tibial division. The group consists of the medially situated semitendinosus and semimembranosus, paired laterally with the biceps femoris. An elegant anatomical exception exists here. While the long head of the biceps femoris is innervated by the tibial nerve, its short head originates directly from the femur and is supplied by the common peroneal nerve. The hamstring part of the adductor magnus works alongside them to assist in hip extension. This slide showcases the intricate clinical anatomy of the thigh. At the upper third, we dissect the femoral triangle, bounded by the inguinal ligament, sartorius, and adductor longus. Its vital contents are arranged from medial to lateral using the classic mnemonic: femoral vein, femoral artery, and femoral nerve. The femoral ring within this space represents a weak structural point, vulnerable to femoral hernias, which occur more frequently in females. Moving distally, we observe the adductor or Hunter's canal, roofed over by the sartorius muscle. This narrow conduit transports the femoral vessels and the saphenous nerve toward the knee. Any focal compression within this tight space can result in severe ischemic or neurogenic symptoms. In the lower leg, presented here is the master summary matrix for the 3 thigh compartments, grouping their complex anatomy into a unified reference framework. The matrix categorizes each compartment by primary action, nerve supply, muscular exceptions, and arterial source. The anterior compartment extends the knee via the femoral nerve and artery, noting the dual innervation of the pectineus. The medial compartment adducts the thigh via the obturator nerve and artery, highlighting the hybrid nature of the adductor magnus. The posterior compartment flexes the knee via the sciatic nerve and receives blood from the deep perforating arteries, reminding us of the short head of the biceps femoris. This matrix ensures clear baseline logic for clinical diagnostics. Descending below the knee, we analyze the crural region, starting with the anterior and lateral leg compartments. The anterior compartment contains muscles dedicated to the dorsiflexion of the foot and extension of the digits, the tibialis anterior, extensor digitorum longus, extensor hallucis longus, and peroneus tertius. This functional group is strictly innervated by the deep peroneal nerve and supplied by the anterior tibial artery. Conversely, the lateral compartment contains the primary foot avertus, the peroneus longus and peroneus brevis. This smaller compartment is regulated by the superficial peroneal nerve, drawing its blood supply from perforating branches of the peroneal artery. Together, these compartments prevent foot drop and optimize ground clearance. We now explore the posterior leg compartment, the absolute power source for plantar flexion and forward propulsion. During the push-off phase of gait, this extensive compartment is completely innervated by the tibial nerve and supplied by the posterior tibial artery. It is anatomically divided into two layers. The superficial layer contains the large, prominent muscles forming the calf, the gastrocnemius, soleus, and the vestigial plantaris. These muscles coalesce distally into the massive Achilles tendon, the strongest tendon in the human body, inserting into the calcaneus. The deep layer contains the popliteus, which unlocks the knee joint to initiate flexion, along with the flexor, digitorum longus, flexor hallucis longus, and the deep tibialis posterior, working together to invert and stabilize the foot. This slide focuses on three critical clinical conditions frequently encountered in the leg and foot. First, we examine foot drop. This condition stems from an injury to the common peroneal or deep peroneal nerve, often due to a fracture at the narrow neck of the fibula. The loss of dorsiflexion causes the foot to drag, forcing the patient to adopt a high-steppage gait to clear the ground. Second, we look at the Thompson test, a simple clinical maneuver for diagnosing an Achilles tendon rupture. Squeezing the calf muscle normally produces passive plantar flexion. Its complete absence confirms a full tendon tear. Finally, we address plantar fasciitis, an inflammatory wear of the thick plantar aponeurosis supporting the sole, which presents with severe heel pain during the first morning steps. This slide displays the master summary matrix for the leg and foot, beautifully consolidating the relationships between these lower extremity hujurat. The table splits the region into four areas: anterior for dorsiflexion via the deep peroneal nerve, lateral for eversion via the superficial peroneal nerve, and posterior for plantar flexion via the tibial nerve. Crucially, it adds the plantar foot, detailing the intrinsic muscular layers, responsible for stabilizing the foot arches and refining toe movement. These intrinsic muscles are controlled by the medial and lateral plantar nerves, distal branches of the tibial nerve, and supplied by the corresponding plantar arteries, showing that the neurovascular organization remains consistent all the way to the digits. We conclude our anatomical survey with this ultimate synthesis slide, which maps the entire neurological control system of lower limb movement. This brilliant tree diagram illustrates how spinal nerve roots from lumbar 2, L2, through sacral 3, S3, weave into the lumbosacral plexus 2, emerge as the major terminal nerves we have discussed. We trace the clear pathways, the femoral nerve to the anterior thigh, the obturator to the medial thigh, and the sciatic nerve, branching into tibial and peroneal divisions to control everything below the knee. This elegant map confirms the definitive anatomical law displayed at the base of the slide. One nerve defines a specific fascial compartment, and one fascial compartment defines a specific biomechanical action. Thank you for following this blueprint of movement.